Afternoon, and welcome to the Johns Hopkins 30-minute COVID-19 briefing, where we provide live insights from the experts who lead our work at the Johns Hopkins Coronavirus Resource Center. For the next half hour, we'll focus on what you need to know right now about the COVID-19 pandemic and public health responses. As part of this briefing, we'll have an opportunity for live Q&A with our experts, and we'll be offering these 30-minute briefings regularly on Fridays at 12 p.m. I'm Dr. Lainie Rutkow, a professor at the Johns Hopkins Bloomberg School of Public Health, and I'm part of the leadership team for the Johns Hopkins Coronavirus Resource Center. We'll be providing answers in real time today, so please submit your questions in the box at the bottom of your screen. As always, there's much to discuss with our experts. Today I'm joined by two guests. Dr. Jennifer Nuzzo is a senior scholar at the Johns Hopkins Center for Health Security and an associate professor at the Johns Hopkins Bloomberg School of Public Health. Jennifer will give us an update about the public health implications of the COVID-19 data. Dr. Bill Moss is executive director of the Johns Hopkins International Vaccine Access Center and a professor at the Johns Hopkins Bloomberg School of Public Health. Bill will give an update about COVID-19 vaccines. I'll now turn to each of our experts for a brief overview. Jennifer, we are seeing declines in cases, in deaths, in hospitalizations. Do you see these trends as reason for optimism? And what, if anything, are you seeing that is cause for concern?
Thanks, Lainey. I do think that there is reason to have hope and to be optimistic. These case declines and the declines in deaths and hospitalizations are very much welcome after several months of record highs in all of those categories. So I am quite hopeful about these trends. That said, there are still a few things that we're kind of keeping an eye on that are potentially, I won't say cause for worry, but just things to be mindful of. The first is one that I talked about on multiple briefings, and it's still very much an issue, which is that we continue to see declines in the number of tests being performed each day across the country. Now, as cases decline and infections decline, we would expect fewer people to need to be tested. But the reality is these declines are more likely administrative or operational because as states are rolling out vaccines, they may have shifted their attention. And the worry about that is that we might be missing people who are infected, people who may be infected and not know it because they haven't been tested, and they can go on and spread their infection. And we very much worry, and we've seen this happen at other points when testing has been constrained, where the infections circulate kind of silently for a while until all of a sudden they become quite apparent. So that is still something that we have to be mindful of. Nationally, the test positivity has fallen for below 5%, which is the first time we've seen that in a while, and that's great news. But it's not falling everywhere, and some states have seen increases lately, most likely as they are dialing back on the amount of tests that they do. That means that the people who are getting tested are the people who are most likely to have COVID, the sicker people. And so that's when test positivity goes up. And in those states, it's very much a sign that it is time to expand testing to make sure we're not missing sort of the bottom of the iceberg of infections. The other thing keeping an eye on is the cases and the deaths this week were a bit different from previous week's trends, and where we have seen actually a small bump in deaths this week. Similarly, the case declines this week aren't as low as they had been in previous weeks. I think it's too early to infer too much about this, particularly since we know the data have been interrupted due to weather-related interruptions in a number of states. And so what may not have been reported earlier may have been bumped over to this week for reports. I usually look at a full week's worth of data to say what's happening now, and 2 weeks worth of data to say if we're in a trend. So that's something that I'm going to be looking at going forward. Of course, we remain concerned about the variants, and there were a lot of headlines this week about variants, and I think the bottom line is still the same. The measures that we take to control the spread of COVID are the same measures that we're going to use to combat the variants. So really critical that we keep up our efforts to vaccinate and roll out vaccines as quickly as possible. Also really important that we continue with the social distancing and all those other measures. And I guess one of the concerns has been is that as states see decline in their cases, which is clearly good news for them, they're very tempted to kind of lift all of their restrictions. And, that creates a situation where we could see case increases again. So while these trends are great and I'm quite hopeful, nothing is guaranteed. And we still have to remain vigilant and continue to scrutinize the data, but also continue to remember that we're very much in this, and that just because cases are falling, there's no reason to think that it couldn't go back up.
Thanks, Jennifer. Still nice to hear a little bit of optimism in our briefing this Friday. Before I turn to Bill, I want to remind our audience to please submit questions for Jennifer and Bill in the box at the bottom of your screen. Bill, the vaccine rollout continues. We've heard some good news about the Johnson & Johnson vaccine this week. Of course, concerns still remain about when supply will meet demand. Can you talk us through these latest developments?
Yes, thank you, Lainie. And another really busy week in the COVID-19 vaccine world. And, I too have reasons for optimism. Here in the United States, we've delivered almost 92 million vaccine doses, administered just over 68 million. We're averaging about 1.5 million doses per day. And about 14% of the US population has received one or more doses, and 6.5% two doses. So we still need to do better. We'd like to see the doses administered per day on average, I would say 2 to 3 million per day. And obviously with just 6.5% of the population having received two doses, we have a long way to go there. I'm going to start off by talking about some of the news this past week around the Pfizer and Moderna vaccines, and then we'll turn to the Johnson & Johnson, which is the big news of the day. Earlier this week, the main vaccine manufacturers testified before Congress, and we heard from both Pfizer and Moderna that they've solved some of the manufacturing challenges that they've faced in the early months of the vaccine rollout, and will be able to provide more doses earlier. They're targeting together 220 million doses by the end of March, and we're still hoping for 600 million doses of those two vaccines by July, and that would be enough to adequately vaccinate 300 million Americans, so the vast majority of the American population by July. So we're seeing improvements in the availability of doses for both Pfizer and Moderna. The other good news this past week related to those vaccines, particularly the Pfizer vaccine, was evidence coming out of Israel, published on Wednesday in the New England Journal of Medicine, showing that vaccine effectiveness in the real world was very close to the efficacy we saw in the phase 3 trials, with symptomatic infections reduced by 94%. And severe disease by 92%. This was a study looking at around a million people with 600,000 individuals vaccinated. So very large population-based study. It was able to be done in Israel because they have these health maintenance organizations that have very good electronic records. So the good news is that as we roll out this vaccine in the real world, outside of the very controlled environments in a trial, we're still seeing very high vaccine effectiveness against symptomatic disease and against severe disease. So good news as well. Just a couple news stories this past week on the variants, and Pfizer and BioNTech announced that they will be looking at what a third dose of their current vaccine does in terms of protecting against these variants, with the idea that this would further boost antibody levels and provide additional neutralizing activity against the variant. So that's an important way forward. And then Moderna's announced that they will be evaluating what's the first multivalent COVID-19 vaccine, where they combine the messenger RNA for against the original variant or strains, and then against this new variant, the B1351, which was first identified in South Africa and is one of the main variants of concern. So we're seeing these two companies, vaccine manufacturers, moving forward in trying to address the problem of the variants that Jennifer outlined. But the big news today is on the Johnson & Johnson vaccine, and as we we speak, the Vaccines and Related Biological Products Advisory Committee of the Food and Drug Administration is meeting to discuss the results of the phase 3 trial of the Johnson & Johnson vaccine. Our listeners will remember that this is an adenovirus vectored vaccine, human adenovirus 26 vectored vaccine. It's being proposed for emergency use authorization as a single dose. And one of the big advantages of the adenovirus vector vaccine is that they can be refrigerated for 3 months. They don't require that ultra cold storage that the messenger RNA vaccines require. So from this large trial, about 45,000 individuals, 72% overall efficacy in the United States and 64% in South Africa, where the variant was circulating. That 64% efficacy from South Africa is slightly higher than what was reported in the press release from Johnson & Johnson a couple weeks ago, which was 57%. I think the really good news here is 86% efficacy against severe forms of COVID-19 in the United States and 82% against severe disease in South Africa. So despite the somewhat lower vaccine efficacy, we still see very high vaccine efficacy against severe disease, and even in a setting where there's widespread circulation of that variant of concern. We also see in the data from the phase 3 trial that this efficacy is consistent across different race and ethnicity groups, across different age groups. There was a report that received some attention of lower efficacy, 42%, in people over 60 with a comorbid conditions like heart disease or diabetes. But people have to understand that these large phase 3 trials don't really have the sample size, the number of individuals participating to really look in detail at these subgroups. So the uncertainty around that 42% efficacy estimate is really wide and extends up to 72%. So we don't want to make too much out of that because the study really did not have what we call the power to really look at those subgroups. Another notable finding is it looks like the reactogenicity, the local side effects, systemic side effects right after receiving the vaccine, somewhat less with the J&J vaccine than the Pfizer Moderna vaccines. About half people reported soreness at the site of injection, maybe about 39% headache, 39% fatigue, and about a third muscle aches. So slightly lower than what we saw in the trials of the mRNA vaccine. They also looked at asymptomatic infection by monitoring the presence of antibodies against coronavirus 2, and saw an efficacy of about 74% against asymptomatic infection. Now, again, the numbers in this sub-study were small, so we're going to have to learn more. But again, some encouraging evidence that that vaccine protects against asymptomatic, or provides some protection against asymptomatic infection. Lastly, Lainie, I'll just end with 2 questions that I think are really important that we still need answers to. One is, would the Pfizer or Moderna mRNA vaccine have similar or higher efficacy after a single dose? There's been a lot of discussion about this. There's no biological reason to think that an adenovirus vector vaccine would do better as a single dose than an mRNA vaccine. There's certainly biological reasons why the adenovirus vector vaccine just requires refrigeration. It's DNA, not RNA. DNA is much more stable, and it's in that adenovirus protein capsid that helps protect it. But basically the bottom line is that the Pfizer and Moderna phase 3 trials were set out to evaluate 2 doses. So we don't have a lot of information on single dose, but I will highlight there is increasing evidence. 2 new studies published yesterday in The Lancet from Britain looking at a single dose of the Pfizer vaccine in people who had prior COVID-19. And it looks like they get an enormous antibody boost, develop that cell-mediated immunity that's very important as well. So I think we may see down the line, there aren't recommendations in the United States yet on this, but it may be that people who've had prior COVID-19 really only need a single dose of the mRNA vaccine. And there are more than 28 million people in the United States who've had documented COVID-19. The last point I want to make, Lainie, is that another question is, would the J&J vaccine have higher efficacy if it were 2 doses? And there is an ongoing phase 3 trial in the United States looking at 2 doses, so we will have really rigorous data on that. One of the interesting things about the adenovirus vector vaccine is whether that second dose, the response to that second dose might be diminished because of antibodies to the actual adenovirus vector itself. Maybe that could diminish the response to a second dose, but we'll have to see.
Thanks so much, Bill. And your ending with 2 questions is a perfect segue into our Q&A. So let me move on. I want to thank everyone who's watching who submitted questions today. Bill, this first question is for you, and it speaks to conversations that we've been having quite a bit within our team on the site. And so here it is. Once J&J is, assuming it gets the EUA and it's being distributed, how are we thinking about reconciling the extent of full vaccination in the population, since we'll now have 2 vaccines that are a 2-dose and one that's a 1-dose? Can you talk through some of our thinking about this?
Yes, it's a really important question because the way data are being reported by the states and collated and presented, for example, by the CDC, is often by individuals who've received one or more doses and individuals who've been fully vaccinated. And that will change if there is an emergency use authorization for a single dose Johnson & Johnson vaccine. Which we all expect in the next day or two. We'll have to see reporting by vaccine type. The CDC does break down, vaccine by Pfizer, Moderna, and we'll have to kind of keep separate track of that Johnson & Johnson vaccine, and because we will just be counting single doses and would technically consider that a fully vaccinated individual.
Thanks, Bill. Jennifer, some questions about testing for you. So as the distribution of vaccine continues throughout the country, what is the right way for us to be thinking about the role of testing moving forward?
Testing remains essential. I mean, we still have to diagnose people who are infected, and that hasn't changed. I mean, the vaccine doesn't compete with that. It's not as though getting vaccinated means you're going to get a positive test. So you shouldn't worry about any kind of interference there. And so certainly if you meet the criteria to be tested, particularly you've had an exposure, you have symptoms, you should absolutely seek out testing. Now, it's a little bit of a harder question in people who have been vaccinated. But I think it is important if you have symptoms to still continue to get tested, because one of the things we have seen reports where people have been vaccinated and then subsequently diagnosed with infection. And I think it's important for us to continue to maintain surveillance for that. So I don't see any diminished role of testing. It's unfortunate that's been scaled back, likely due to only so much bandwidth in the system, but it's very much important.
Thanks, Jennifer. And I want to pick up on what you just said about testing being scaled back. So we have a question related to that. And how can we be sure that the declines that we're seeing now in cases shouldn't actually be attributed to scaling back in testing?
Sure. So one of the ways that we evaluate that is to look at the positivity, and that's either the percentage of people of tests performed or the percentage of people tested that comes back positive. That has consistently been falling, so that gives us greater confidence that these declines are true declines, though at the beginning I was quite worried about that. That said, as we start to miss more infections because perhaps people who might have otherwise been tested are not getting tested and they may go out there and infect others, that can lead to the silent spread of infections even more so than we've had since the very beginning, that only becomes recognized when somebody gets quite ill and ill enough to get tested. So that we've often seen that situation where there's that silent spread and then all of a sudden we see a bunch of cases because it finally made it to the people who are most likely to get iller and more likely to be infected. So I remain concerned. However, the fact that we are seeing downward trends in test positivity as well as hospitalizations and deaths help sort of corroborate the fact that that there are real drop in cases.
Thanks, Jennifer. Bill, turning to you for some vaccine questions. What do we know so far about side effects or adverse events related to the COVID vaccines, and especially the Pfizer and Moderna that already have the EUA?
Yes. So there are several sources of data on vaccine adverse events. So obviously we have the very rigorous the collected data from the phase 3 trials, both for Pfizer, Moderna, now actually for the J&J, and so that consists of what we call passively reported, where people just report what they get, and where they actually solicit adverse events. And so that's kind of all collated from the phase 3 trial. But obviously, here in the United States and elsewhere in the world, we've vaccinated millions and millions of more people. And so that's data being collected through a number of different mechanisms by the Centers and Disease Control and Prevention. And then that's actually summarized through meetings, regular meetings at the Advisory Committee on Immunization Practices. So people can actually go, those presentations are made publicly available, and go to the CDC or ACIP website, and you can actually see the meetings and presentations. And they summarize the data that are being collected on adverse events through these various mechanisms. Again, some of it is, a lot of it's passively reported through various systems. There's something called a VSafe app that people can report the adverse events they have. And and all that is being very carefully looked at. Now, the bottom line is that to date, we've not seen any additional serious adverse events that weren't identified in the phase 3 trial. I'll say, with the exception of the anaphylactic reactions that have occurred that were not identified in those phase 3 trials. But for example, Bell's palsy there was a small signal of potentially increased risk of Bell's palsy in the phase 3 trials. We're not seeing that in the post EUA rollout of the vaccine. But I want to emphasize to folks that this is being looked at very carefully by the CDC through a number of reporting mechanisms, and people can access those data on the ACIP website.
Thanks, Bill. Several questions about the vaccines and transmission. Can you talk us through what we know so far? Can the COVID-19 vaccines prevent transmission of the disease?
Yeah, this remains, a very important question, a commonly asked question. And the way the way studies have tried to get at this, I'll say, is somewhat indirectly, just because measuring direct transmission from one person to another person, that's not an easy thing to do. It can be done, but that's a different higher level of study design. So what we're looking at is, can people have asymptomatic infection? Because if these vaccines prevent asymptomatic infection, they're very likely to prevent transmission as well. It's a sign that the level of virus in the nasopharynx is very low or undetectable. So we have evidence from a number of different sources on a number of different vaccines that these vaccines can prevent asymptomatic infection. Not as high, the efficacy is not as high as with symptomatic disease and certainly severe disease, but we do have evidence. So I mentioned the evidence that came out of the J&J vaccine, 74% efficacy against asymptomatic infection, looking at antibody responses. There's data from the Moderna vaccine as well as AstraZeneca vaccine that they too can prevent asymptomatic infection. Not completely. So some people who are vaccinated can become infected or will become infected and probably can transmit the virus.
Thanks, Bill. Another question for you. So given what you said earlier about folks who already know that they had COVID-19 and then what we're seeing after they get vaccinated, should individuals who know for sure that they had COVID-19, what should they be thinking in terms of the second dose of the Pfizer or Moderna vaccines?
Yeah. So this is a really important question, and right now the guidelines from the Centers for Disease Control and Prevention are that people who've had prior documented COVID-19, those individuals should receive 2 doses. That is the current guideline. So I don't want to mislead people into think those guidelines have changed. And that's because the antibody response is quite variable after COVID-19. It seems to be lower in people who've had milder disease, certainly asymptomatic disease. But because of that variability, because we don't know whether they'll be protected or not, it's recommended to have 2 doses. As we get more data, it is possible, and I know there are many experts who believe that this will be the case, that we will have sufficient data to say that a single dose is warranted or reasonable in individuals who've had prior documentation of COVID-19. But right now, the recommendations are 2 doses, and people should continue to follow those guidelines.
Thanks, Bill. Jennifer, question for you as we see cases falling. So there are a lot of moving pieces right now. There's the vaccine rollout, there's human behavior, there are also the variants that we're learning more about every day. So given all of those pieces, what is your best guess about what happens in the weeks to come?
So I'm hopeful that we'll see continued declines. I think that what we're seeing right now is a mixture of vaccine plus natural immunity plus behavior change. And it is important, though, to realize that some of those things can change, and particularly as we return to mixing, some of the spread that may have been stemmed just by people limiting their interactions could increase because people increase their interactions. So it's still, I think, a critical time for people to adhere to the protections that we have been doing for the last year. I am hopeful, though, that that's not going to be forever, and that we could see big changes, in the months to come.
Thanks, Jennifer. We are just about at 12:30, so I'm going to give you the last word for today. I'd like to thank Jennifer Nuzzo and Bill Moss for joining me. Give a big thank you to all those who are watching, and especially to those who submitted questions for our experts to answer this afternoon. As always, this briefing will be archived and available at coronavirus.jhu.edu. As a reminder, we will offer these 30-minute briefings regularly on Fridays at 12 p.m. And in each briefing, we'll focus on what you need to know right now about the COVID-19 pandemic, and we'll have live Q&A with our experts. I'll look forward to seeing you at our next 30-minute briefing. And until then, thanks and stay safe.